People of all backgrounds and circumstances are made by God to be loved and cared for with dignity and compassion until the time of death. In a study published by the Institute of Medicine in 2014, however, it was revealed that the end-of-life experience in the United States is often characterized by futile care, physical and emotional distress, and spiritual suffering. It is evident that transformation is needed in the ways our society, not just our healthcare system, cares for seriously ill people, their caregivers, and their families. We know the solution. It is excellent medical care that is provided in ways that are highly personal, honest, tender, and loving. We call that comprehensive person and family-centered approach whole person care. Our Whole Person Care initiative is a formal, organized palliative care and faith community-based program being introduced in California. Through a partnership of the California Catholic bishops and the state's Catholic healthcare systems, the Whole Person Care initiative seeks to provide compassionate and loving support for terminally ill people, their families, and their caregivers. The initiative, which will also collaborate with others in the medical and faith communities, is designed to expand and enhance both spiritual and medical care to people living with life-threatening conditions, helping them make informed, ethical decisions consistent with their personal values and priorities as they approach the end of their earthly journey. By leveraging and expanding existing diocesan training systems, we will develop networks of volunteers in parishes who will provide skilled and compassionate pastoral support to frail and dying people and the families who love them. The initiative will strengthen ministries, dioceses, and parishes by making tools and resources available to support and implement whole person care. Additional pastoral applications include spiritual formation, extraordinary ministry for the sick and dying, bereavement ministries, and faith community nursing and social work programs. In the healthcare settings, the initiative will promote humanizing hospital spaces, enhanced training of palliative care specialists, establishing active collaborations between clinics and parishes with shared goals and metrics to improve care and quality of life for frail and dying people and their families. The initiative will build from evidence-based guidelines and national expert consensus recommendations to refine patient care processes. It will also provide a full-time service where patients can access palliative care as needed 24 hours per day. Through the initiative, a continuum of personalized, coordinated disease treatment and palliative care will become the standard in Catholic-affiliated hospitals in California. The initiative will comprise well-trained teams of physicians, nurses, and parish-based staff who recognize the transformative potential of this project. Together, we will demonstrate the feasibility of clinicians and faith-based community members to provide the best possible medical care, along with comprehensive spiritual, social, and emotional support for whole persons through the end of life. Our goals are twofold: to further education and training in parishes and Catholic healthcare to ensure that all who are physically dependent, seriously ill, frail, or dying feel wanted, worthy, and dignified, and to make the Whole Person Care Initiative's program and services available to Church and Catholic healthcare leaders for implementation elsewhere. Starting from where we are, Catholic healthcare and Catholic faith communities can work and learn together with the goal of providing reliably excellent, tender, and loving care for people through the end of life. Loved, wanted, worthy.
We are delighted to have the opportunity to chair this session. My name is Eduardo Brera, and I work at MD Anderson Cancer Center in Houston.
I'm Thomas Sitte from the German Palliative Stiftung and the Children's Palliative Care team in Germany as well.
In these meetings that are very intense and that have so many sessions, sometimes it's even hard to know if we are in the session we want to be in. This is the session on vegetarian cuisine. I hope you all are. And being right after lunch, we invite you to remain awake because this is important, this is huge. Policy and financial perspective is what might make this happen or not. We discuss how important this is from a clinical perspective, spiritual perspective, but if we can't make it happen from a financial and policy perspective, you will not have jobs and your patients will not get treated. And so we have a fantastic panel today to address these very, very important issues. Our first speaker is going to be Dr. CharlesNormand. He's a professor of health policy at the Center for Health Policy and Management at Trinity College Dublin, Ireland. And this is a center that has been particularly focused on the financing, organization, and delivery of health care with a trajectory of great work in the area of long-term care and palliative care. And we're delighted to invite him to talk to us about achieving value for money in palliative and end-of-life care.
Okay, thank you very much. Thank you for coming after lunch and still being here. The organizers made one big mistake. They failed to point out that they were keeping the best till last. And this is going to be the most enjoyable session of the whole meeting. It's the most enjoyable one because, in contrast to Anne this morning, I'm actually delighted to be talking about economics and using the language of economics. It's what makes life good for me. And it's what I hope makes life good for everyone else as well. It is also a breach of human rights to ask any academic to speak for 20 minutes, and so I will only... All right, but it has to grow taller then. I'll be... praying and giving a presentation together is too complicated for me. So I'm afraid that some of the things I'll be talking about, I will only be giving a very brief flavor and trying to concentrate on the key points. And really the three key points I want to make, if you want to write this down, so if you do fall asleep, you'll have the key points available to you. The first is, these issues we're talking about are here, will always be here, and we need to embrace them and not be concerned by them. Second, it's difficult. In case you didn't get that one, it's very difficult because doing good studies on the value for money and the cost effectiveness of palliative care is very difficult, and the measurement issues which I'll be talking about are very key. And the third point is simply that we do in fact have quite a lot of evidence, and we need to try and draw on that evidence, and we need to identify where the evidence gaps are and try to build on those. If you don't notice that's what I say in the presentation, it was because you were not paying attention, not because I wasn't doing the right thing. So healthcare choices always have to be made. They are always with us. We always make choices on how we use resources. Sometimes we make choices without people seeing it, but we always make choices. Sometimes we make bad choices, but we always make choices. Running away from the need to make hard choices doesn't make them go away, it just makes it more likely they will be addressed in inadequate and insufficient ways. But in palliative care, the lack of good evidence on value for money and cost effectiveness has often been mistakenly seen as evidence of no value. So the lack of evidence of value is taken as evidence of no value. And I've often heard people say really intelligent things like, it doesn't really work. Not addressing the question of what it is or what we mean by work, but it's very commonly thought. And good evidence is easy to assemble where the objective is simple and the treatment is simple, so that you can easily measure something that is easy to identify with easy objectives. But in palliative care, the objectives are complex, the interventions are complex, and putting together good evidence is therefore very difficult. So, as I said, economic evaluation works very well where the interventions are simple and where the outcome is simple. So, for example, evaluating an eye surgery program, it's pretty simple. You know how many people have impaired vision. At the end of it, you know how many people have got good vision. You know they like it, they appreciate it, they can read more. It's a good thing. And you can work out how much it costs to do because you know how much the surgery costs or whatever the treatments are. It's pretty straightforward. And a whole body of experience has grown up around evaluating relatively simple interventions. And I would include things like hip replacements as fairly simple interventions. Can't walk without pain, can walk without pain. Not a terribly complicated change. It has some profound effects, but it's pretty simple. But with complex interventions, some of the metrics that are commonly used don't really work very well. Partly because it's actually difficult to measure what the intervention is sometimes. I'll be talking a bit more about this, but it's often a team effort, it's a collaboration, it's working through people, it's trying to change some of the underlying understanding of what we're trying to do, it's trying to change the planning of care. It's often doing things that are some distance away from simply saying, we do this treatment now. Most of the best metrics in current use work very well where we know simply what we're trying to do, what we're trying to achieve, and how we can link the intervention with the outcome that follows. In complex interventions, as I say, it's often difficult to define exactly what we're doing, but often the effects depend on what other people are doing around us as well. It's no good simply to say, I've got a really good support for decision-making if the change in decisions don't lead to a change in treatments. It has to be done through teamwork and that sort of thing. Also, people have an irritating habit of having opinions, wanting things, wanting to take part in the decision process, allowing their preferences to show. All these other inconveniences that take away that nice, simple, linear relationship between the problem and the solution. And people tend to have different views on what they're trying to achieve, what their goals of care will be. And often the outcomes are difficult to measure, and there are a number of reasons, and I'll touch on a few of them later on. This might seem like what we would call teaching your grandmother to suck eggs. That's to say, telling people things they already know. But palliative care is an approach as well as a service. It's a way of thinking as well as a way of doing. The goals may change and evolve as we go through the trajectory of needs and trajectory of care that we provide. We don't know on the first day what the pattern of needs and wants is going to look like, and we have to be able to adapt and change. It's inherently a team game. It's not a game that is well played by individuals. Another important point, and one I want to keep emphasizing, and I'm going to be a little dull on this subject because I'm going to come back to it several times. Often what people are looking for is availability as much as wanting actually to use a service. And this is something that we've found in our research to be hugely important to people. If I need it, will it be there? Not, I want it on Tuesday. And that need to be able to provide things in a timely way and a way that doesn't stress either the family or the individuals is a crucial part of a lot of what we're trying to do in palliative care. And also, outcomes can depend on a multitude of different things that we're trying to do. We're not simply saying we are putting in a pain control intervention. We're doing a pain control intervention in the context of a number of other things that are being done to try and help the outcomes and the quality of life. Another problem that makes comparison with other services difficult is often in palliative care we're looking at quite a short time horizon. People will often measure in ways that I'll be talking about in a minute, like quality adjusted life years. if you're dealing with an intervention that may have a duration of 6 weeks, you don't get very many life years out of 6 weeks. Even if it's better than perfect, you don't get very many life years out of 6 weeks. Now, just a few challenges on measurement, and I'll be running through these ridiculously quickly, but I just wanted them to be on the record so people could access the slides and the text. Defining the intervention can be difficult, and therefore what is it we're trying to measure can be difficult. I once knew a nurse who worked for the Macmillan Cancer Nursing Service who didn't actually see patients. She only saw people who saw patients. She worked through people. So if you counted how many patients she saw, the number was 0. But how much difference did she make? We hope the difference was huge. So availability can be more important than use. So how do you measure the availability of service for someone who doesn't use it, despite the fact it can be of great value to them? Interventions are often bespoke, and therefore it's not easy to define their overall content because they've been designed one by one for the different people who need them. Interventions occur over time and are linked to each other, so you don't know in advance what the interventions will be because they will change as a result of what's going on. My only question, though, is this in fact something that is very specific to palliative care, or is it indeed really the context for a high proportion of the healthcare we deliver? And one of the other sub-messages I'd like you to send you off with today is that to a significant extent, the world is out of line with palliative care. It isn't that palliative care is out of line with the world, because people treat medical care and health care as if it doesn't have these characteristics, when in most cases I think it does. A nice statistic I always like is the fact that the great majority of people who see a family doctor have 2 or more chronic diseases at the time they see that doctor. It is very rare for someone to go and see the doctor because they have one problem. They almost always have multiple problems, and that means the context for that intervention is very different. A question of how wide we cast the scope when we're trying to assess costs in palliative care, because very often it is working with a broader group and you have to look at all those knock-on effects. And some things that we do in palliative care are cost neutral or even cost saving, and I'll give some examples before the end, because some of the things we do actually reduce costs of care rather than increasing it. How do we cost things we don't use but are important to be there? How do we cost linked activities over periods of time? And how do we cost the consequences of effective palliative care? Now, we have a number of similar issues around assessing benefits. As I said, the widely used tools that are often used, like SF36 or EQ5D, if anyone doesn't know what these things are, they're in a happier state than I am, because you would often lose the will to live before getting to the end of some of this debate. But these are measurement tools that are trying to adjust our understanding of people's quality of life or their capacities, and you can use them to judge whether an intervention has changed or has not changed these things. But when you apply tools like this in palliative care, overwhelmingly you find it doesn't seem to show up as making much difference. So you often have the paradox that if you ask people how much they value something, they say they value it hugely. They then fill in the form and it shows that they didn't value it at all. Now, there are 2 possibilities there. One is that people are all stupid, and the other is that the measurement tools aren't working very well. I'll leave you to decide for yourselves which is the more likely explanation. But we have a lot of evidence that these kinds of tools only partially pick up differences that people consider to be important. And I'll come back briefly to this at the end. And there are 2 reasons, I think, for this. One is that the scope that these tools try to pick up tends to be too narrow, and the metrics they use to measure tend to be too insensitive. So there are good reasons, I think, why these tools don't tend to do well. Now, there is a body of research that is trying to develop better tools, and this is still in fairly early stages. I mention only 2 here. One is a set of tools that are called IceCap, based on the underlying ideas of Amartya Sen about capabilities that have now been developed to try and understand how palliative care type interventions do or do not make a difference. Another is the development of the widely used POS measures, which is trying to take measures that are commonly used in palliative care and convert them into ones that will show differences in health-related quality of life. The evidence around these suggests that they do pick up differences in a more sensitive way, and there's, I think, a lot of reasons to be quite optimistic that we're going to get better at measurement in this area. The problem remains, though, is how we ensure these measures are seen as comparable to measures that are used in other fields. Because unless you measure in a comparable way, it's difficult to make comparisons. And we have to be in the business of making comparisons because comparisons are the basis for decisions on resources. Another problem, though, is the problem of time scale. And again, if I had my full 55 minutes that I should be allowed here, I would give you a lot longer on time scales. But the issue around time scales is most measurement tools simply say an hour, a day, a week, a month is just a month. And it's a thing you can measure and you can add them together. But if you imagine yourself going on holiday, if I said to you, how was your holiday? You said it was really great because I had 15 days instead of 14 days, and that extra day made all the difference. It made it a holiday that was worth 8.5% more. Does any of you say that? Or do you say, I had a great holiday. It had a great time in the middle, and I came home after the family all got together and they were nice to me. That was, so the way you think about something like a holiday doesn't say it was the addition of day 0, day 1, day 2, day 3, day 4, day 5. It was, how did I feel about the whole experience? And yet people will go around measuring outcomes of healthcare interventions as if you can add up the days. My argument is, in some senses, you can't add up the days. If you try and add up the days, you get nonsense because that's not the way we conceptualize an experience. It's not irrelevant, but it's not the simple way in which we do that. So time, I think, cannot simply be added. And I said I can be very long-winded on that subject, but they were not allowing me to be. An alternative approach, then, is to try and measure what people value. Can you measure more directly? How do people feel about different packages of care, different experiences of care? What are the things that really made a difference to them? How would they make better choices? And we've done quite a lot of work using a technique called discrete choice experiments to try and understand what people really like. What are the things that really seem to matter to them? What are the characteristics of care that seem to make a difference? And you can ultimately begin to say, does that give us a basis for looking at value for money? Is it good value because it does things that people want and it does things they want well? And a number of interesting things have come out of this work, not least the style of delivery is often at least as important as the content. People didn't simply say, it was very good because they did the following assessments. They gave me the following treatments. It's saying, when I wanted someone, they were available. And when they were available, they were trying to help me with my problem. And I wasn't left hanging, waiting for people to be available on Monday. You know, it's a great coincidence that people, when they're sick, choose to be sick only Monday to Friday, 9 to 5. At any other times, they're obviously well. And yet, we organize our lives around the possibility that people have this nice pattern of ill health that only occurs conveniently on weekdays and not too late in the evening. I know that a lot of us do organize our care in a more benign way, but if you look at the overall provision of healthcare, it's got that tendency to shut down. People are very resistant to be left without support, and one of the things that comes through very strongly is the preference people have for well-coordinated access to competent, skilled individuals at the time when they may need that help. And I can come back to that if I've got time at the end. So I'll give a few examples of what people have shown us really matters in the style and the things that make a big difference. I say, first of all, process as well as content, the style of delivery as well as the content of delivery, availability, avoiding hassle to informal caregivers and families, ensuring that people have access to support so that you're not putting the overall burden too heavily onto families and informal caregivers. And minimizing this burden on family is valued particularly because if the family isn't burdened, it's able to do what it can only it can do. I'll just come back on this for a moment because I think it's a very important finding, and that is, in general, families seem to have something approximating a fixed time budget available to provide informal care. If formal care takes a lot of the burden off them, they do the other things that they want to do, which are more spiritual, more supportive, more to help the whole person. If formal care is not available, they tend to do more of the routine physical management of someone's needs. And we've traced this in some detail, what people actually do as a result of different levels of formal care being available. That means that if you hassle the family, you take away the thing the family does best and nobody else can do best. So I think there's great importance in understanding the importance of supporting those who support as well as supporting the patients themselves. Prepayment, that's to say not delivering someone a bill on the day when they take the service, is hugely valued. That's to say getting access without feeling you're negotiating what you're paying for and who's paying for it and how it's being paid for. And that's clearly valued to a huge extent. And participating in making choices is also valued to a great extent. Now, I'm just going to finish by giving a few examples of things we know from studies that have been done that suggest we can actually use some of the existing evidence quite well. First of all, from a study looking at palliative care specialists put into emergency departments. And the key thing that came out of that was you can reduce the number of people admitted to hospital, you can reduce their length of stay, and you can get better experience of quality of life if you do that. We've got similar issues in studies we've done in other countries, which have shown expert decision-making can improve the experiences and improve outcomes and can reduce the amount of treatment people have, and they show better experiences at the end of that. I'm just going to skip ahead because it's more important to get to this. Sorry, my slides are not what they're meant to be. I will just have to finish without looking at them. The other thing I was wanting to emphasize is that a number of studies we've done in the US have shown that if you put a palliative care team into a context of someone admitted to hospital with life-limiting disease, it unambiguously shows that they have a better experience, better quality of life, they have fewer treatments, and they have a shorter time in hospital. It also, in some studies, not ones I've been directly involved in, has shown that people live longer as well. In these cases, we're saying palliative care is free. It's more than free because it releases resources. And if something does a better job at a lower cost, it's actually quite difficult to construct the argument why you shouldn't do it, if you can get better for less. And I think we've got to look for, first of all, for where we can get better for less, and then we say if it is better for more, it's probably got to then show that it's better value because it gives you more for more. I'm sorry, there seems to be a problem with the slides as they've come out, so I have been a little incoherent at the end, but I just want to repeat my 3 points in case you didn't notice them at the beginning or have forgotten. First of all, these issues are with us forever. They're not going to go away. We must embrace them rather than run away from them. Second, it's difficult to do some of these measurements, and some of these evaluations are hard to do. And thirdly, we do have some evidence, and we should be trying to move to use that evidence to argue the case for resources, particularly where they are unambiguously good value, as they are, at least in hospital care, in trying to improve people's experience of hospital care by providing expert support for decision making. Thank you very much.